Assalamu alaikum everyone. The next topic of discussion is shingles. So it's usually common in individual greater than 60 year of age and more common in female as compared to male. What are the causes? So causative pathogen is varicella zoster virus. Primary infection causes chickenpox while the reactivation of varicella zoster virus causes shingles. Transmission so is transmission occur via respiratory droplets and direct contact. Risk factors so reactivation typically occur in immunocompromised individual like those having advanced age, patients suffering from malignancy, HIV infections, patients taking immunosuppressive therapy, malnutrition, and chronic stress. What is the underlying pathophysiology? So primary infection causes chickenpox, respiratory transmission, VZV inoculates the lymphoid tissue of the nasopharynx and subsequently renal lymphoid tissue. Viremia and chickenpox occur. Recovery from chickenpox, so the virus remains dormant in the dorsal root ganglia unless reactivated. So after reactivation, it causes recurrent infections. Reactivation is known as shingles, while primary infection is known as chickenpox. So VZV reactivated often many years after the primary infection, especially in immunocompromised individual. The virus replicates in the dorsal root ganglia, travel through the peripheral sensory nerves to the skin, and leads to the shingles. What will be the clinical features? So main symptom is that in shingle there will be dermatomal distribution, typically affecting 1 to 3 dermatomes on one side of the body, most commonly affect the cervical, trigeminal, thoracic and lumbar dermatomes. Pain the most frequent symptom and usually described as burning, throbbing or stabbing, and allodynia may occur. Allodynia is the stimulus that usually doesn't cause pain, but in a patient suffering from the shingles, a mild stimulus may cause the symptoms. There will be erythematous maculopapular rash that typically evolves into vesicular lesions. Vesicles are initially clear, pustulation and rupture 3 to 4 days. Crusting and involution occur between 7 and 10 days, and lesion may become necrotic, generalized, or may not be present at all. What will be the additional symptoms? So, fever, headache, and fatigue, paresthesia, loss of sensation, itching, motor deficit is rare, and children, the course is usually mild. Then we have disseminated infections. So herpes zoster is called disseminated when involvement contains greater than 20 extradermatomal lesions and there is involvement of greater or equal to 3 dermatomes and our visceral organ involvement is there. So in viscera we can have lung involvement leading to pneumonia, acute course with dyspnea, tachypnea, chest pain, hemoptysis, and on imaging there will be nodular interstitial infiltrates. Liver inflammation leading to hepatitis, CNS involvement, meningoencephalitis, eye involvement, acute retinal necrosis, and these are typically seen in immunocompromised patients. Atypical presentation can be present in immunocompromised individual, and the atypical presentation will be there will be no rash, recurrent herpes zoster, and disseminated zoster. These are the atypical presentation. Then we have subtypes and variants of the varicella zoster virus involvements. So we have herpes zoster ophthalmicus. Herpes zoster ophthalmicus is the reactivation of VZV in the ophthalmic division of the trigeminal nerve and occur in 10 to 20% of the cases. Clinical features, so there will be fever and skin symptom as we have discussed earlier. Herpes zoster conjunctivitis, keratitis, and involvement of ophthalmic nerve. So there will be a reduced corneal sensitivity. So this is the important point in viral infection that the corneal sensitivity decreases with severe pain in the innervated region like forehead, bridge, and tip of the nose. Involvement of the nasociliary nerve, so possible severe intraocular infection, uveitis, iritis, conjunctivitis, keratitis, and optic neuritis, and there will be positive Hodgkinson sign of the nose. So it's a vesicular rash on the nasal ala. These are the clinical features. Diagnosis, so we can do the slit lamp examination and fundoscopy, and treatment is start antiviral therapy for herpes zoster because it's a life-threatening vision-threatening condition, and oral analgesia and lubricating eye drops to help manage the pain. Complications so can result in blindness and glaucoma. Herpes zoster oticus is the reactivation of VZV in the geniculate ganglion, affecting the 7 facial and 8 vestibulocochlear cranial nerves, also known as Ramsay-Hunt syndrome. Epidemiology And then clinical feature, we have fever and skin symptoms as in shingles. So these will be present in the auditory canal and pinna. Vestibulocochlear involvement will lead to vertigo and sensorineural hearing loss, and facial nerve involvement will lead to ipsilateral facial paralysis. Diagnosis, so tone audiometry is done to check for the hearing loss, sensorineural hearing loss. Herpes zoster, herpes zoster oticus and ophthalmicus present with identical rashes, so their rashes are identical. Diagnosis, so clinical presentation is usually sufficient. PCR of the DNA is done for the confirmation of the infection, recurrent herpes zoster and atypical presentation. So these are the indication for the PCR, and it can be performed on the skin lesion, CSF or blood. So additional test, we have serology, SFR, IgM, IgG can be used to identify active or passive immunity and diagnose primary VZV infection. Direct fluorescent antibody DFA of skin scraping, it's not routinely recommended. Anti-zinc of the skin, not routinely recommended. It has low sensitivity and specificity because it's positive in other infection as well. On the smear, we will have multinucleated giant cell with eosinophilic intranuclear cowdery A inclusions may be seen. Patients with recurrent infection are disseminated, so consider evaluation for underlying malignancy, immunosuppression, and other causes of like herpes simplex. Treatment, so if the rash onset is less than 72 hours, start oral antiviral in patients with clear indications. Start IV in those patients who are immunocompromised, having disseminated infection, having neurovascular involvement like VZV encephalitis, VZV vasculopathy, herpes zoster ophthalmicus with retinal involvement. Antiviral therapy can also be considered in patients without clear indications. Rash onset, if the rash onset is greater than 72 and no new vesicle continually appearing, so same treatment as discussed above. If new vesicles are appearing, so the treatment is same as discussed above. If there are no new vesicles, so consider supportive care alone. For patient with uncomplicated, consider antiviral in patient with age greater than 50 with immune deficiency or evidence of complication like disseminated zoster neurologic involvement. Supportive care, so provide routine wound care and adequate analgesia and consider steroid in selected patients. Now antiviral therapy for the herpes zoster infection. So antivirals indications are age greater than 50, moderate or severe rash and pain, immunocompromised patient, sign of disseminated zoster and or neurologic complications, and non-truncal involvement like herpes zoster ophthalmicus. So these are the indications for the antiviral as we discussed above. Regimen, so for immunocompetent patient, choose any of these: acyclovir, valacyclovir, famciclovir, and for immunocompromised patient and are those with disseminated zoster, so give IV acyclovir. Now we have anti-inflammatory and analgesic. So pain control is vital to maintain patient quality of life and prevent post-herpetic neuralgia. General principles, so consider prescribing medications regularly. Reassess frequently to ensure adequate analgesia and consider using standardized scale to monitor pain. Recommended regimens are: for mild pain, you can consider acetaminophen, NSAIDs, and weak opioids like tramadol. For moderate to severe pain, so we can add one of the following like a strong opioid oxycodone, nortriptyline, gabapentin, pregabalin, and corticosteroids. Corticosteroids, so these can be considered in patients with CNS involvement or those with cranial nerve involvement like facial nerve palsy, herpes zoster oticus. Herpes zoster ophthalmicus, especially if there is significant periorbital edema and severe pain. These are the indication for the steroid use. And then we have the options like prednisolone and prednisone. Complication is post-herpetic neuralgia. It's the most common complications. And it's a chronic neuropathic pain persisting for at least 3 months in the area previously affected by the rash. Most common complication and strong association with age. Risk factor are age greater than 50, severe infection, ocular involvement, immunosuppression. Clinical feature, we have pain, including allodynia, paresthesia, dysesthesia in the same dermatome as the rash. Duration of the symptom greater than 3 months but can persist for years. What will be the treatment option? The initial choice of analgesic should be guided by the side effect profile, the potential drug interaction, and patient comorbidities. One of the following TCS can be used: amitriptyline, nortriptyline. Relative contraindications, so patient with heart disease, epilepsy, or glaucoma should be used with caution and elderly. One of the following anticonvulsant can be used: pregabalin, and gabapentin, topical treatment like capsaicin and lidocaine, opioids like morphine, oxycodone, tramadol. Pain typically continues to decrease over first year but may last for months to years. So that's all about postherpetic neuralgia, and then we have herpes zoster encephalitis. Risk factors are the same: immunosuppression, more than one prior episodes, herpes zoster with cranial nerve involvement and disseminated infection. Clinical feature usually manifest as acute or subacute delirium within days of vesicular eruption, focal neurologic deficit, and additional like headache, fever, meningismus, ataxia, seizure. Diagnostics: so we have CSF analysis and MRI. CSF will show pleocytosis, leukocytes will be elevated, and PCR positive for the DNA. MRI will show plaque-like lesion in the white matter, signs of demyelination, and late finding can be hemorrhagic infarct or ischemia. So treatment is antiviral acyclovir and steroids. Prognosis: so mortality is approximately 10% of the patient, and chronic encephalitis in immunocompromised patient may have a very poor prognosis. And these all are the additional complications. And now prevention. So routine chickenpox immunization and shingle vaccination are recommended for eligible individual. Vaccination consists of 2 doses of recombinant zoster vaccine or RZV administered 2 to 6 months apart. So 2 doses and administered 2 to 6 months apart. At risk individual should be begin RZV immunization series regardless of the previous shingle outbreak or vaccination. What are the indications? So indication are individual greater than 50 without contraindication to vaccination, and immunocompromised individual greater or equal to 19 years of age, including those with HIV. Special considerations: to avoid vaccination of patient with active infection until the symptom improve, and consider deferring vaccination in pregnant individual because it's contraindicated during pregnancy. RSV is different from the varicella vaccine and should not be administered for the prevention of chickenpox. Screening for varicella is not routinely required prior to the shingle vaccination. This is the image showing the shingle infection, and these are present in a dermatome like distribution. So what are the dermatome involved here? It are T4 and T5 dermatome involvement is present here. This is another lesion, another picture showing the shingles present in the dermatome T1 and T2. So always remember that shingle involvement is dermatomal. This is another picture showing the shingles. This is the image showing lesion in C2 and C3 dermatome. And this is the image showing herpes zoster oticus with involvement of the facial nerve. So oticus with facial nerve involvement is known as Ramsay-Hunt syndrome. And this is the image. This is the image showing multiple grouped vesicles, herpes zoster oticus. And this is the image showing the eye involvement known as herpes zoster ophthalmicus. And this is the Hodgkinson sign, which is the involvement of the nasociliary nerve. And these are the lesions present on the L of the nose. So that's all about shingles.